Well, good afternoon, and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. July is Fibroid Awareness Month, and our topic this month and today is uterine fibroids and fertility. Thank you for joining us. I am Dr. John Frattarelli. This is Dr. Goulet, and we're going to discuss fibroids and everything about fibroids in the next 20, 30, 40 minutes. Please leave questions if you have them in the chat, and we'll get to those. We do have a couple of other questions that have already been assigned to us, so we'll start with, what are fibroids and how do they form?
Right, and so I tell my patients that fibroids are muscular growths within the uterine muscle. So the uterus is a muscular organ, very similar to other muscular organs within the body. The muscle cells within the uterus, though, can sometimes grow a little bit out of control. And when that happens, we do call it a tumor. So technically fibroids are a tumor, but they're, for the most part, a benign tumor where we don't worry that these could turn into cancer and become life-threatening. But they can have other effects on the reproductive health for a woman. So you may come across the term that these are muscular tumors or uterine tumors. Well, technically that's true. One should not be scared or overly concerned that this could mean a cancer diagnosis, because that's very rarely the case. But because they are abnormal growths, they do have some other effects on the reproductive system, including that of pregnancy and fertility. We'll get into that a little bit later, but also with pain and with bleeding. And so we'll touch on that as well.
Correct. So I guess, we are often asked, why do I have a fibroid? Why is it there? And the answer we give is we don't know. It's just gonna happen. There's some evidence that it could be there's a small genetic component, but it's hard to know why people have fibroids, except that you have a uterus. And the classic was that about a third of all women have fibroids, although I've seen recent studies that show that really up to maybe 70 to 80% of women have fibroids. And when you really look at everyone's uteruses, and especially as you get older, you're more likely to have fibroids and be diagnosed with fibroids. So it's very common. You would say, somewhere probably half of women, if not more, are going to have fibroids in their lifetime. And like Dr. Goulet said, it's a smooth muscle tumor. It's thought to just be like one muscle cell that kind of gets out of control, kind of like a cancer. It starts with one cell and gets out of control, and that's the same thing, but it's not cancerous. However, there is always a risk that it could be cancer, and so that's why we certainly look at it. The chance of a normal fibroid that's growing normally and appears to be normal to be cancer is exceedingly low and does not require surgery or evaluation. A fibroid that's acting abnormal. So that's the good thing about cancer, is that it kind of says, hey, look at me, and will act up and will grow really fast and get really large and cause lots of different symptoms. And so those are the fibroids that have to be looked at. And even those fibroids oftentimes aren't cancer. But those are the ones that we always are looking at very closely. We send to the oncologist, or we'll send to surgery. They'll send to have surgery done to evaluate that fibroid.
Absolutely true. Many women, they'll have a CT scan for a random reason when they're in their 60s or 70s, and will find an incidentally found fibroid that's the size of a marble and was a complete non-issue for their entire life and won't ever be an issue. That being said, some fibroids do become an issue, and there is a racial predilection. So women who are of African American or Black descent can have heavier fibroid burden and may be more likely to grow more fibroids or to grow large fibroids compared to other races and ethnicities.
And as far as removing fibroids, there are different types of surgical procedures that are done, and a lot of it depends on where the fibroid is, how big the fibroid is. For like fertility purposes, If the fibroid is not involving the cavity of the uterus where the baby would grow, then probably it doesn't need to be removed. However, there's always the caveat that maybe it does. Maybe it could be large enough that we would deem that maybe it should be removed. But most fibroids, if they're not involving the cavity of the uterus, don't need to be removed. And typically for fertility purposes, if it's involving the cavity and coming into the cavity of the uterus, typically we can do a hysteroscopic procedure. That's where you take an instrument, let's say the size of a pencil, goes through the cervix into the uterus. It has a camera on the end so you can see inside the uterus, and you can shave those fibroids out. As long as there's enough of the fibroid in the cavity of the uterus. If most of the fibroid's in the muscle, but a little bit's in the uterus, then or in the cavity, then most of the time that procedure is going to be an open procedure or a laparoscopic procedure, not a vaginal or hysteroscopic procedure. And those types of surgeries, and that discussion comes along when we diagnose the fibroid and see what options you have.
And I love those hysteroscopic surgeries. Those are some very satisfying surgeries because we're able to treat them fairly quickly. There's a fairly quick recovery time from those surgeries. The bigger fibroids, though, the ones that require us to either do laparoscopy, which are cameras through the belly button and the belly in order to cut out the fibroid, or to do an incision very similar to a C-section scar, like a bikini cut incision. Though when the fibroids reach that size, the healing and the recovery from those surgeries is a little bit longer. We do want the uterus to completely heal up before attempting pregnancy. And so often there's a several month delay before we would recommend trying to conceive again, or proceeding with an embryo transfer if you've done IVF after those surgeries. So there is a risk that after you've had fibroid surgery for a large fibroid, that the integrity of the uterus when it's laboring may not be as strong as it was before the surgery, and we don't want to risk the uterus rupturing or tearing apart where that scar and where that incision was. And so those individuals, we would recommend have delivery via C-section prior to the onset of labor, so typically at 37 weeks.
Correct. And that's something that you would discuss with your OBGYN at the time of pregnancy. And I guess speaking of pregnancy, how do fibroids, impact fertility and pregnancy? We kind of talked about this earlier. The cavity of the uterus, the lining of the endometrium, which is where the embryo attaches, and then the fetus would grow inside the uterus. If there's something inside the cavity, then that's going to potentially affect the implantation and the ability of that embryo or baby to grow and develop. Which is why we'll want to remove that to make sure the cavity of the uterus is normal. Fibroids can also be large enough or in a position where they may block the fallopian tubes. And so it may be difficult for somebody to get pregnant because the fibroid's impinging on the fallopian tube, and so the sperm and the egg can't meet. They, depending on, again, size and location, there is an association maybe with miscarriage and with fibroids. And someone who has who has lots of fibroids in the uterus or really large fibroids may also have some difficulty in pregnancy or labor. Certainly if it's a cervical fibroid down by the cervix, where the baby's going to be kind of passing through, that can sometimes cause problems. However, I should say that we're always concerned, because we know that there's going to be a problem with it, so we take care of the fibroid. But as far as OBGYNs, when there's a lot of fibroids in the uterus, there's always the concern that the fibroid could be an issue, but it usually isn't. Yeah, but it's always better to be cautious than just blow it off. So certainly the one thing that also fibroids can cause, if there's something, especially in their cavity of the uterus, you can cause recurrent pregnancy loss. So sometimes when patients are having miscarriages and they'll come to us after having a couple of miscarriages, part of the diagnosis is, what's the uterus like? Is the uterus normal? Is there something in the cavity of the uterus? And oftentimes we'll find polyps or scar tissue or fibroids or something in the cavity of the uterus that's contributing to those miscarriages.
Absolutely. And so I have quite a few patients who ask me, well, is surgery the only thing that can be done for these fibroids? Or when do I need to plan on having my surgery? I have a 2 centimeter and a 3 centimeter. They're in the muscle, but they're not big yet. But how big will they grow? When do I need to plan on having the surgery? And unfortunately, every fibroid has its own time span. I cannot predict when that fibroid is going to stop growing. Many of them will stop growing when they're the size of a quarter or the size of a ping pong ball, but some of them can grow quite large to the size of a grapefruit or larger. And so typically we try to take a conservative approach. If it's not impacting the cavity and it's not very large and it's not causing severe pain symptoms or bleeding symptoms, then we'll try to hold off on surgery. But certainly there's a threshold that we cross where we think it is impairing fertility, or the pain is so severe, or that it's growing too large and affecting bleeding, that those would all be indications for surgery as well. But as far as other ways to treat fibroids, there are other ways to treat fibroids other than surgery. The problem is that most of those medical therapies that we could recommend or offer would also prevent conceiving. And so other therapies for fibroids consist of hormonal therapy. So sometimes women will be put on long-term progesterone therapy or combined oral contraceptive pills to see if that can help alleviate maybe some of the heavy bleeding that can be associated with fibroids. There's a wonderful new medication called elagolix. That's the generic name that is available, that's showing some promising results in helping with fibroids as well. And then ultimately there's another medication called depo-lupron, which induces a medical menopause, which can help prevent these fibroids from being problematic from a bleeding standpoint. But medical therapy can't erase or make these fibroids go away. They're sort of a Band-Aid to help prevent the bleeding and maybe temporize the pain symptoms. But unfortunately, how they act hormonally also prevent us from pursuing pregnancy if that's the treatment modality that's chosen.
And I guess the other thing, the other treatment is getting older. Because once you go through menopause, typically the fibroids start to shrink a little bit. They're feeding off the estrogen that's being produced. When you're ovulating in your normal menstrual cycle. So women who are menopausal, typically the fibroids will start to shrink at that point, or at least stabilize. So it's rare that people, when you're in menopause, actually have symptomatic fibroids. I guess one of the other things that we may want to discuss is, what makes a fibroid symptomatic. Obviously, we are typically concerned about fertility for patients, but for other patients who aren't necessarily wanting fertility, or maybe they are wanting fertility, you still can have symptoms that would lead you to either see your GYN doctor or a fertility doctor for the fibroids. And so that's typically going to be, pain. You might have very heavy menstrual cycles that even cause you to have anemia, where your blood count's low. I mentioned miscarriages earlier, recurrent pregnancy loss. The fibroids, as they get larger, you might feel that your abdomen's getting a little bit bigger. You might even be able to feel something. You might, some patients will be able to feel the fibroids, in their abdomen or on their belly. You can have pain with menstrual cycles, or pain, just pain in general, depending on where the fibroid is. The fibroids, sometimes you'll see them in the back of the uterus, and they kind of set against the spine almost of the patient, and they may have some spinal nerve symptoms.
Or constipation.
Correct.
From resting.
So a lot of different, there's really a constellation of symptoms that people will have that might lead you to go see a GYN doctor, and be diagnosed with fibroids. But then it also could be just a normal uterus. You might have some other, issue going on that your GYN doctor might find as well.
So some of the other surgical treatments that are available, while for fertility reasons, we consider the gold standard to be resecting it or removing it, cutting it out. There are other procedural or surgical treatments available. The problem is we don't turn to them, to those modalities from a fertility standpoint, because it's been either demonstrated that they're not safe for pregnancy afterwards, or it has not been proven yet to be safe for pregnancy afterwards. But if you have a fibroid burden and you're wishing to avoid an open surgery or laparoscopic surgery, there are other ways fibroids can be treated through procedures. Some of them are available in Hawaii, not all of them are, but one can consider, I think this is focused MRI energy into the fibroid, or there's a radio frequency ablation of these fibroids where they stick a needle probe directly into the fibroid, and for lack of a better term, they microwave these fibroids to destroy them. There is also a uterine artery embolization where they can cut off some of the blood supply to the arteries leading to the uterus that will cause these fibroids to infarct and to naturally sort of involute on their own. And then last but not least, there is hysterectomy. So if you've completed your childbearing journey and you're tired of having fibroids, when you remove the uterus, for the most part, those fibroids can't grow back.
I guess, leading into that, or following on with that, if someone has, really significant fibroids and the uterus just can't be repaired, and there's just so many symptoms and you need a hysterectomy, that doesn't necessarily mean that you have to be done with fertility, right? So, just getting a hysterectomy doesn't necessarily mean removing the ovaries. Okay, so removing the uterus, you don't have to remove the ovaries. And so you still can use a gestational carrier as an option if there's not a uterus present, or if the fibroids are just taking over the uterus so much that you don't think you're able to carry a pregnancy, for whatever reason. And then with the procedures that Dr. Goulet just mentioned, certainly hysteroscopy, removing the fibroid, very gently making sure the cavity of the uterus is normal is the gold standard for us, or doing what we call laparotomy, a C-section incision to remove the fibroid, or laparoscopically going through the belly button. Those are all kind of the gold standard for us for fertility. However, all of the other procedures are done, and we do see patients who've had those and are wanting fertility, and certainly there are patients who get pregnant with those other procedures. The problem is we don't know that if you come to us and you have a fibroid, that removing it in any way other than surgically, if those are safe, meaning that you're going to have a very good chance of getting pregnant, or is that going to affect your chances of getting pregnant? And do you have a better chance of getting pregnant if you were just to have surgery or not have surgery at all? And that's the issue, because for instance, the uterine artery ablation, that's affecting the blood supply to the uterus. When you're pregnant, the baby kind of needs blood supply. And however, there's a lot of blood supply going to the uterus still. And so there are patients who've gotten pregnant with uterine artery embolizations. But we don't know if it's, what the potential risk is as far as lowering your success rate with those types of procedures, which is why we wouldn't necessarily recommend those initially.
Right, or increasing the risks to the pregnancy. Right. I think there is some, some data that does indicate that by reducing that blood supply to the infant, that we increase the risk of abnormal placentation and earlier.
What's placentation?
that placenta might implant in a way that's not normal, where it will try to either invade and grow too deep into the uterine muscle, or try to grow over the cervix when it's not supposed to cover the cervix, because that's the hole that the baby's supposed to come out. So we do worry that there can be some abnormalities with these other procedures. But that being said, you can't rely on this as birth control either. So just because you've had a uterine artery embolization does not mean it's impossible for you to get pregnant. We just believe that there's a reduced chance of fertility after that sort of procedure.
Correct. I'm not sure that I have anything else to add about fibroids.
We haven't had anybody pipe up yet.
Yeah, no additional questions. I guess one thing I always like to at least mention during these is, what a typical discussion is like with a patient. And so maybe you can kind of share what your discussion is with a patient who comes in who has fibroids, and you're talking to her about surgery versus no surgery, chances of getting pregnant after surgery, things like that.
Yeah, a lot of that depends on the individual, their ovarian reserve and their fertility standpoint beyond the fibroids, and then how big and where these fibroids are located. But in general, I tell them that with any procedure, there's always the risks of bleeding, infection, and damage to nearby and involved organs. We are very careful while we do the surgery, but if there's been a prior surgery on the uterus, maybe there is fibroids earlier, and this is the second or the third time around that we are removing fibroids, that could be an increased risk of damage to the uterus or to nearby structures. Depending on how big the fibroid is, there may be quite a bit of blood loss during the surgery. And so there are things that we do during the surgery to help reduce the blood loss. Certainly, if you are anemic going into the surgery, we do recommend iron therapy and trying to, if it's due to iron deficiency and chronic blood loss, we do recommend we get your blood count levels up to the normal range before proceeding with surgery. But if we aren't able to achieve that and we're going into the surgery knowing that you're anemic, knowing that these are large fibroids, there may very well be a need for transfusion during the surgery as well. And intraoperatively, we have things that we can do to try to minimize that blood loss, but those only can go so far before, if I feel any of my patients' life may be at risk or in danger due to blood loss, I won't hesitate to transfuse my patients so long as they have given me permission ahead of time.
Yeah, I think that one of the things that patients are always surprised to hear, I guess, is if we're doing a myomectomy, an abdominal myomectomy, meaning like a C-section scar, they lose a lot more blood with that than they do if we do a hysterectomy and take the uterus out. Because when you're doing a hysterectomy, you clamp the blood vessels automatically, and so you decrease. You're basically taking care of the blood supply. With a myomectomy, you're not doing that. You're just cutting through the uterus, usually just getting a lot of blood. So that's why for myomectomies, the most common complication that happens is they get a transfusion, and the more fibroids you have, the larger fibroids, the larger they are, the more likely there is to, and then the lower your hematocrit is going in, the more likely you are to get a transfusion. That's the most likely complication that will happen. For fibroids that are inside the cavity of the uterus and you have to do a hysteroscopic procedure to shave them out, the most common complication is that you can get a little bit of scarring afterwards. And certainly scarring in the uterus is kind of like having a fibroid in the uterus. It's
not ideal.
Doesn't work very well. But what I always tell my patients is that, well, you 100% of the time you have a fibroid, because you have a fibroid right now. It's not going to be 100% of the time after we remove the fibroid that you're going to have scar tissue. In fact, it really kind of varies on how, what it looks like, but it's probably, less than 10% of the time that you'll get some scarring afterwards.
Okay.
And so most of the time you're going to be able to fix that. And even if you have scarring afterwards, you can usually do a second procedure and take care of that. So most patients, the cavity of the uterus is going to be very normal, after you finish. The other question that I get or I discuss with my patients always is, they'll have fibroids in the uterus and the cavity's fine. But maybe they've had a miscarriage, or maybe they've had trouble getting pregnant, and the fibroid's large, 5-centimeter fibroid, 6-centimeter fibroid, which is the size of a baseball, right? And which is the size of a normal uterus. So it's basically having two uteruses there. And so then the question, when we're doing ultrasounds, it looks huge. And so the question is, why can't we just remove that? And certainly the studies that we have suggest that there is a detriment to having a fibroid. If you have a fibroid in the uterus, your uterus isn't going to function as well as it would if you didn't have that fibroid there. Okay. However, if you have a fibroid in the uterus and you do surgery to take that fibroid out, you're causing the same amount of damage to the uterus by taking it out as the fibroid is causing by being there. So the success rates with fertility are exactly the same typically if you're going to do, if you remove the fibroid or you leave it in place. So for that reason, we're not really helping you by removing it. So there's no reason to remove it. And again, with that said, there's sometimes that's not 100%. Sometimes because of the location, because of the size, we might recommend removing it, or because of you've had 3 losses or other reproductive issues where we'll say, well, there's no downside to trying because maybe it's having more of an effect than we think. Okay, but generally, if it's just a 4-centimeter fibroid, we're not going to recommend removing it unless it's involving the cavity or where the baby would implant.
Right. In general, I tell my patients my cutoff tends to be at around that 7-centimeter mark. Once it's grown that big, if it's in the musculature, there's a pretty decent chance that when we do our imaging studies that it is impacting the cavity regardless. It's hard to grow that big without also deflecting or impinging on the cavity. And so by that size, we're pretty much going to need a surgery regardless. But there's that gray zone between the 3-centimeter to that 7-centimeter mark where it can be sizable, but not yet really impacting the cavity. Back in the day when Dr. Frattarelli and I were doing deliveries and we're doing C-sections, we all saw women who were able to get pregnant and to carry a pregnancy to term, and we would do their C-sections and point out their large fibroids and be like, oh, hey, isn't that interesting? But the reality is although those fibroids were not subfertility factors for those women, doesn't mean that every fibroid is a non-issue for every woman.
I agree. I don't have anything else to add. Anything else, Neil?
I think that pretty much wraps it up. It was a delightful
Yes.
conversation today. Thank you guys all for joining us today. Once again, this was Ask the Docs here at the Fertility Institute of Hawaii. Feel free to send us any questions or message us if you have anything else that you'd like to add to this discussion, and we hope that you will join us next month.
Aloha. Bye, guys.